Thank you, Pedro. That was really extremely motivating as always. And I just had two things in my mind while I was listening. So one of them is that I think we should never forget that everything that we know today, our basic knowledge, as this is also for the young generations, is really based actually on the innovative and creative work of our forefathers, what you have been doing there in Maastricht and around the world for in the 1980s, 90s. But for a second, that I was also finding incredible that, so when you think that you are doing something really original and you are the first one to think about it, which I'm looking at Mariana, that we have been doing this spacing from one side and looking at the local block with our highest density mapping system. And then you see that tracing, pacing from one direction and looking at the Venkiba, already published, 30 years ago. Then you realize that, it's probably we need to read these old publications also. So I don't know if anybody has any questions from the audience. Please come and ask. I'm asking both of you just to start with. That Pedro, I always heard this from you also, that you were busy with alcohol, and then the radio frequency ablation came, and it has done so much wonderful work in the last 30 years. And we had this discussion with you yesterday about radio frequency energy being so ineffective and creating inhomogeneous lesions. And if I see this, maps that you are showing, is this, so we are moving back to the way to create homogeneous lesions, and probably that's the reason when alcohol is working, also anterograde or retrograde. And do you think that, with the come of PFA, or we are still should be on search for a new energy, which is not creating this incredible inhomogeneity, but is creating this kind of clear-cut lesions as alcohol? Do you want to...
Well, I think that with the present techniques that we have, you will be much more specific that this is the alcohol. When we use that arterial approach, of course, this was a little bit brutal. At least brutal, if not even worse than brutal, no? Because we try to spare as much myocardium as possible by using the cold saline mapping. So first be sure that we had only the one artery that was actually providing the blood flow there. But today it should be possible to be, he actually has shown how you can reduce the area by avoiding that your alcohol will go away or that will attack other areas, etc., because you can delineate that much better. I think it would be very good. Maybe you should include an arm with anterograde ablation in your velvet trial. I would be very interested to do it again. Even when they say that I'm retired, but I think that, to be honest, that you can be. The other thing, don't forget the words of Doc Sipes, markers of. We are now dealing with our mapping systems are basically using the electrical signals. That's how we look at our channels and all these things, etc. But there are already chemicals which cannot be used still in humans because they are very toxic to label these myocardial cells. And I'm sure that it will not take 20 years that one biochemist will come with a product that will label, will radio label or whatever our cardiac cells, and that you'll see this perfectly well, that you'll see. What I mean by that is the action potential mapping that is done in the experimental lab. That should come one day, and then we are talking, then it's another world.
So my 2 cents on this, I think, so right now, even though we localize the veins to the substrate and we create these fancy maps, we have the scar and we see that the vein is in the scar, still alcohol is pretty much barbaric. It's a weapon of mass destruction, and I think if this is the future, I sure hope not. I think the future should be, getting a little bit more sophisticated with the biology. Just like COVID vaccine allowed us to get familiarized with mRNA delivery for whatever, for a vaccine purpose, we could capitalize on mRNA delivery through these approaches into targeting biologically our substrate, and in the future, perhaps, reconstitute the myocardium and do fancier and more sophisticated things biologically rather than just putting a crude toxin in there. But for now, it works. But to your point, it is a mass destruction. It is not subtle. We try to realize it, and it just so happens that in large substrate we have kind of carte blanche to be aggressive because the substrates are already large. But hopefully, one in the future, we get a bit more sophisticated with what we do.
Thank you so much. It's a very beautiful presentation, both of you, of course. I would like to ask a question following also. For everybody who want to ask a question, there are microphones everywhere, please, because we are also streaming. So if you want to ask a question, take your chance. My question is quite clinical because, we have this the AP fellow, and the risk is that Monday morning they come there and this procedure. Hello? To all our patients because is the last type that we have. No, my question is clinical, is what is your percentage of patients that they deserve this procedure? What is the typical stratification that you do before you select your patient for this procedure, just to have an idea what is the percentage of people that they deserve this approach?
I hope nobody deserves it, but I mean, no. In general, what we do is obviously I get some referrals that are specifically for this, and it's not like we do ischemic VTs every day. We do maybe 4 or 5 a month, something like that, and in general, once now that I have already built up a fair amount of experience, basically I do the map. I have the fellow work on the endocardium ablation, and then in parallel I just shoot some venograms and see. And the idea is to provide the patient the best procedure that we can. If with RF we get the job done and tachycardia is not inducible, we stop there. If there's a good vein in the substrate, then I can put in a multipolar catheter in the vein, and then the important thing is that this is a lot of fun. From the EP standpoint, it's not just the interventional technique, which is fun too, but it's much more fun when you put catheters in there and you do entrainment and you can, wow, look at those signals. So there's some amazing things that I didn't have time to show. For example, when you map epicardially, sometimes the very disease process that is causing the scar in some non-ischemic cardiomyopathies, you have fat, and the epicardial map shows you low voltage or nothing, and then the vein in the same location gives you nice late potentials. So sometimes the epicardium is obscured by the disease or fat in there, and we get good, cool signals that are fun. But to your point, what's the percentage? I think the more you do, the higher the percentage it gets. So I would say for ischemic VT, I use it in about half of the patients. Of course, if they're in a clinical trial, it's randomized. And then non-ischemic, I have very low threshold.
Just to follow so you always map epicardially to see what is the best signal before ablating? Not
epicardially necessarily, veins. Yeah, so all my VT cases, I get geometry, I map of the veins. I put a decapolar catheter in there and get not only the signals from the veins, and of course not all the veins, but I get the main coronary sinus, anterior interventricular vein, and maybe a lateral vein. And that's just, you put a quadripolar in the RV. Well, I put the decapolar vein. And that's my ventricular catheter. And then I have that geometry already done, work on the endocardium, and then.
Yeah, Miguel, fantastic presentation, but it's a super new challenge for electrophysiologists. Also, the alcohol ablation of the vein of Marshall. I hope I get more experience, but I'm struggling with it enormously. But Pedro made me puzzle. The integrate approach, what is your opinion? Why are we not doing it integrately by the artery? Is that you think we have a more controlled way of doing it by the vein, retrograde, that we create less collateral damage?
I think it's number one. I think is familiarity. I mean, I shoot coronary angiograms 2-3 times a year now. I mean, I don't do it every time. I do coronary angiograms when I'm in cases of epicardial elevation that I'm worried about something. But In general, it's not something that we do all the time. I guess part of choosing an approach comes from your experience. I am not as old as Pedro, but I'm old enough that when we trained, in my general cardiology fellowship, we were doing primary angioplasty. There were no interventional fellows. All the fellows did it. So we had the skills and the familiarity with the tools. And I think I was one of the last generations of getting that experience. Most TP fellows now have never done coronary angiograms or a very, very limited experience. So that is one thing. But I tell you, you gotta not be intimidated by it. One of the things that I'm also very, very proud of and is that I was trained in a way to not be intimidated by trying new things. So, and with the Veno Marshall, at least for our cases, it's the biggest difficulty with this is understanding the anatomy. Mm-hmm. And that's, so it's not your skills, it's not your hands, is your mind and your understanding of what it is that you're looking at and how to best, deal with the individual anatomies. The Veno Marshall, when I proctor people, half of the time they're not seeing what is there. It's not that the Veno Marshall is not there or that it's hard to cannulate, it's that they're not looking at the right way to find it. Yeah.
Great presentation, thank you. Where do you position the internal ablation compared to radiation therapy? Radiation therapy.
Oh, that's a good one. I don't know. I have mixed feelings about radiation therapy. Right now, it's a matter of now I put a lot of time and effort in working on this, and we were going to be part of the variant trial on radiation, and obviously I have now personal commitment to the alcohol, and I'm accountable to the NIH that's giving money, so I got to put my efforts, and it competes directly with that trial, so I'm not going to put any patients in the radiation. But in terms of where it fits, I think the radiation has the same problem that alcohol may have. It's just a matter of targeting it properly. Nobody questions that radiation kills tissue and creates scar. Well, some people were saying that it was improving conduction and some nonsense. But in general, it's obviously a tool to destroy tissue and create scar. What I don't like about radiation is that you deliver it and you may be seeing its effects decades later. I mean, we see patients with coronary arteries after mediastinal radiation for Hodgkin's when they were kids, right? And then 30 years later, they have left main disease or constrictive pericarditis. There's cases of esophageal fistulas, like 3 years after radiation. So that has to be ironed out. I think there's been a lot of hype about it because it's, the patient lies on the table and in 10 minutes they're done with the treatment, they go home. But the jury is out, we don't know yet. And it would be really attractive to have a therapy that is delivered non-invasively, for sure. I mean, we pay the price. Ablation is not, we don't do it in every patient post-MI because of the procedural risk and the complexity of it. Yeah.
Thank you very much. There is anybody who want to have a question or comment or? I will thanks again both of the speakers, back from the future and the early future. And I'm very happy that we are on time. So absolutely, I will give you a break. So we have a coffee break on the same room that we have a coffee this morning because we tried to wake you up this morning with this Congress. So then get the coffee again. And then please back on time that we have a very intense Congress that you have to go on. Thank you very much.